Hello everyone. I am Dr. Devender Bairwa, and today we'll be discussing about lysosomal storage disease. This topic is important because lysosomal storage diseases they can present with involvement of multi-system in the body. Mostly they present with hepatosplenomegaly. Some of the diseases they manifest with the CNS involvement, and some of them also involve musculoskeletal system in terms of they can be short height, they can be deformities in spine and cranium. Also, there can be fracture, arthritis, avian. So these diseases are important because first thing is they are rare, and second thing is they clinically they appear similar to each other. So unless we have one gene sequencing and specific clinical features, we cannot make a clear-cut diagnosis in these cases. So here I'm Dr. Devender Bairwa. I have done my DM in clinical immunology and rheumatology from JIPMER. Previously, I worked as senior resident in rheumatology EMC department, and I have done my MD medicine with NIMS and MBBS from MC. So we will be discussing this topic under the following headings. We will first see the introduction regarding these diseases. Then we will see their pathogenesis. We will discuss some selected little more common diseases like Tay Sachs disease, Fabry disease, Niemann Pick disease, Gaucher disease. Then we will see about Mucopolysaccharidoses and then Pompe disease. And last, we will discuss about lysosomal acid lipase deficiency. So these topics are important clinically as well in your papers. Many MCQs will be there regarding these diseases. They appear quite confusing, but if you pay attention, probably you'll be able to understand them well. So as we all know that lysosomes are basically their organelles in cells, and these organelles they have lots of enzymes within, and they are associated with degradation or digestion of many kinds of intracellular molecules, mostly glycoproteins, lipoproteins, and sort of things. So lysosomes are heterogeneous subcellular organelles. They contain many kinds of specific hydrolysis, and they are involved in selective processing or degradation of multiple substances like proteins, nucleic acids, carbohydrates, lipids. And as such, because there are so many enzymes and there can be defect in these enzymes either singly or in combination. As if now there are more than 50 different lysosomal storage diseases, and they have been classified according to the nature of the stored material. For example, one particular enzyme is defective, then that particular substrate will not be digested. That particular substrate will get accumulated in the cell and the tissues, and that's how the names of these diseases have been derived. So, how do they present? How do these diseases of lysosome dysfunction they present? These diseases should be considered in the differential diagnosis of patients who present with the unexplained neurological diseases, renal diseases, muscular degenerations, unexplained hepatomegaly with or without splenomegaly. They can also present with cardiomyopathy, and many of them will have also features of skeletal dysplasias and deformities. So, how to diagnose these diseases? So, in some diseases, there can be disease-specific physical findings, but it is not possible in all the cases. Or we can go for specific enzyme assays, which will show presence of specific enzyme defects. We can also go for gene sequencing. We can see particular gene which is defective. And one thing is that all these diseases within disease and when compared to each other, these diseases may vary in severity so that there can be a continuous spectrum of manifestations. Same disease can present in a severe form, or in other cases, the same disease can present as an attenuated variant. It means with less severe manifestation. So there can be onset of same disease in infantile age or with birth, or there can be juvenile onset disease, or there can be manifestation that appears late in the life. Okay, so function of these lysosome in general in the cell, it includes the replication of genetic material, gene transcription, protein synthesis, and cellular metabolism. So you can consider the lysosome as like a graveyard kind of thing, where all these not required molecules or molecules which require some change will be digested in lysosomes. So this function is actually important with most of the functions in the cells like gene transcription, protein synthesis, or various kind of metabolic pathways in the cell. Coming to classification, so there are so many diseases and they're so rare, it is difficult to classify them in a specific unique way. But what classification we are discussing here is classification that is mentioned in your Harrison, that has been taken from the standard books. So if we see these diseases, there are 8 kind of disorders which have been defined in our Harrison. So there can be mucopolysaccharidosis because of accumulation of mucopolysaccharides because of defect in specific enzymes, or there can be GM2 gangliosidosis, neutral glycosphingolipidosis, glycoproteinosis, mucolipidosis, lipodystrophies, disorders of neutral lipids, and disorders of glycogen. So what we understand here that if you see the names of these diseases, the names have been derived from substrate. So whatever enzyme is defective, whatever substrate is being accumulated in the body, on the name of that particular substrate, diseases have been named. For example, suppose if an enzyme which is involved in metabolism of glycosphingolipids, if that is defective, then obviously glycosphingolipids will be accumulated in lysosome in cells. So these diseases will be known as glycosphingolipidosis. Similarly, if there is a problem with the enzymes which are dealing with mucolipids, and if they are defective, then they are known as mucolipidosis. So in that way, they have been classified. So this table is taken from Harrison, and this table is mentioning these diseases. We will see each group one by one. So this table is actually mentioning mucopolysaccharidosis. And if we see, there are multiple types of mucopolysaccharidosis, type 1 to type 7. Remember the point that there is no type 5 mucopolysaccharidosis, only type 1, type 2, type 3, type 4, then type 6 and type 7 are there. There is no type 5 mucopolysaccharidosis. All of the diseases in general in lysosomal storage disease are generally autosomal recessive, except 3 diseases. One of them is Hunter disease, which is X-linked. Other 2 diseases which are X-linked includes Fabry disease and Danon disease. We will see in subsequent slides. So if you see in this table is showing, apart from the enzyme defect and stored material and their clinical manifestations, what we can see, this table is showing presence of involvement of various organ systems in the body. Like this is showing involvement of neural system, then liver spleen enlargement, dysplasias of skeletal system, eye findings, blood findings, and unique features. So unique features which are unique to particular disease, I have mentioned in this highlighted part. So in this table, you can see MPS type 2, mucopolysaccharidosis type 2, that is Hunter's disease, is actually X-linked. So I have highlighted it. And you can see that corneal clouding is feature of type 1, but not the type 2. So one mnemonic that we used to read in our earlier UG books, that because Hunter has to hunt, so he cannot have a clouded cornea. That's how we can remember that corneal clouding is not a feature of Hunter disease. Also, Hunter needs an egg. Hunter needs an eggs to hunt, so it is excellent. So what we can see that in most of the diseases there are granules in the lymphocytes, but in case of type 1 disease, you have vacuolated lymphocytes. So this is also a specific feature of type 1 disease. In type 2 disease, what we can see that there is a presence of distinctive pabbly skin lesions. We will see photo in subsequent slides. So these are their specific features. Apart from that, all of them can have overlapping kind of presentation, and without particular gene sequencing, it may be difficult to differentiate them correctly. So coming to GM2 gangliosidosis, so basically this defect in enzyme hexosaminidase A or B. Depending on that, there can be Tay Sachs disease, which is basically because of defect in beta hexosaminidase A, or there can be Sandhoff disease. Sandhoff disease will have defect in both beta hexosaminidase type A and type B. So there are different kind of forms, and then we can see both of these are autosomal recessive, and they have involvement of multiple tissue system. And we see that cherry red spot is defined in case of your Tay Sachs disease and Sandhoff disease. Remember, cherry red spot is not a specific feature of these diseases, as it can be seen with multiple other diseases, including some congenital diseases. Then there are some infectious diseases, as well as some drugs are there, which can lead to cherry red spot in your fundus examination. Then coming to neutral glycosphingolipidosis. So this class contains Fabry disease, Gaucher disease, and Niemann Pick disease type A and type B. Fabry disease is because of defect in alpha galactosidase A, and Gaucher is because of beta glucuronidase, and Niemann Pick is because of sphingomyelitis. So this ET SRT, what does that mean? This ET means there is enzyme replacement therapy is available for a disease, and SRT means that substrate reduction therapy is being used. So one way is either you provide that enzyme from outside to metabolize that particular substrate which is being accumulated, or other thing is that you can inhibit or you can stop formation of that particular substrate in the body. In that way, your enzyme therapy and substrate reduction therapy will work. So what we can see, Fabry disease is also X-linked disease, and it has a characteristic feature of painful acroparesthesias, which is not seen with other diseases. Then what we can see that they have cutaneous angiokeratomas and hypohidrosis. So cutaneous angiokeratomas is a distinctive feature of Fabry disease, but it is not specific to it as it can be seen in other diseases. In case of Gaucher disease, what we can see that they have Gaucher cells in bone marrow and they can cytopenia, obviously because of infiltration in the bone marrow. And in Niemann Pick disease, what we can see that there is presence of foam cells in bone marrow, and there can be involvement of lung in terms of pulmonary infiltrates. These foam cells they infiltrate lung and they can lead to lung failure. Coming to your mucolipidosis. So in mucolipidosis, you have mucolipidosis type 2 and type 3. So if you see mucolipidosis 2 is also known as eye cell disease. In this, what is we are seeing that there is a specific mention of gingival hypoplasia. So I would like to mention here that this has been typed wrongly in your Harrison. Actual actual feature of mucolipidosis type 2 is your gingival hyperplasia, which is seen there. And as you can see, this picture has been taken from one case report of mucolipidosis type 2. So gingival hyperplasia is the feature, not the hyperplasia. In your type 3 disease, type 3 of mucolipidosis, what you can see that they have named is like pseudo-Hurler polydystrophy. So what we can make out of it that the features of this mucolipidosis type 3 are exactly like of your Hurler disease of mucopolysaccharidosis. They will be having corneal clouding, retinopathy, then there will be hyperopic astigmatism, coarse facies, and apart from that, there will be stiffness of hands and shoulders. So these are your mucolipidosis. Coming to your leukodystrophies, as the name mentioned, there will be defect in the white matter of the brain. So there are three diseases: Krabbe disease, metachromatic leukodystrophy, and multiple sulfatase deficiency. So these enzyme galactosylceramidase, aryl sulfatase A, and then this particular enzyme which is involved with the multiple sulfatase activity, all these are associated with myelin handling. So what happens if there is defect in myelin handling? There is dystrophy of the white matter of the brain. That's how they are known as leukodystrophy. As we can see in case of Krabbe disease, we can see globoid cells in white matter. And in case of your multiple sulfatase deficiency, all sulfatase in the body will not work because of particular defect, and it will lead to total absent activity of all known cellular sulfatases. Then coming to your disorders of neutral lipids disorders, your lysosomal acid lipase deficiency, it is the part of neutral lipids, and these diseases generally they present in early age with the characteristic feature of adrenal calcification, which is seen in case of infantile onset disease, or in case of Fabry disease, where there is defect of acylceramidase, we can see that there is presence of specific subcutaneous nodules. So apart from that, we know that disorders of glycogen, they either present with your dominant muscle involvement or they present with predominant hepatosplenomegaly. So what we can see that Pompe disease, late onset glucosidase deficiency, and Danon disease, these diseases are associated with lysosome defects. So in case of your Pompe and in case of your late onset disease, we can see that there is defect in alpha glucosidase enzyme. And in case of your Danon disease, there is defect in LAMP2. So this LAMP2 is nothing but it's a protein which is present on the membrane of lysosome, and it is associated with some transport of the molecules. So what we can see in these diseases, glycogen is being stored in case of your lysosomes. It is not being metabolized. And Danon disease is X-linked. possibly dominant inheritance is also seen. And characteristic feature of Pompe disease is cardiomyopathy that actually presents in infantile form. So this table was to just show you the name of the diseases, as well as few diseases have few characteristic feature. Whatever is important, we have mentioned in the highlighted form. Now we will discuss about these diseases with in detail with some common diseases with their specific features. So coming to specific features of disease. So this table is important because whatever we have discussed, now in this table you can see that what diseases have what specific features. So as far as inheritance is concerned, all the diseases are autosomal recessive except your Danon disease, Hunter disease, and Fabry disease. These three diseases are there which are X-linked. Apart from this, everything is autosomal recessive. Coming to Hunter disease, as we already discussed, Hunter has an X, so X-linked. Hunter also wants to have a clear cornea so that he can hunt. So clouding of cornea is not a feature of Hunter disease, and they have characteristic pebbly skin lesions. Then Tay Sachs, Niemann Pick disease because of sphingomyelinase enzyme deficiency, and they typically have cherry red spot in their fundus examination. Fabry disease, because of acroparesthesia, they present with lancinating pain in their fingers and toes. Angiokeratomas, they are specific maculopapular raised eruption like skin lesions. Angiokeratomas are generally seen in case of your Fabry disease, but these are not pathognomonic because they can also be seen with the fucosidosis. Then enlarged tongue is feature of alpha aminocytosis, and mucolipidosis too actually present with gingival hyperplasia, not hypoplasia. So these are specific feature of these diseases. So coming to pathogenesis, why these diseases are occurring. So we have basic idea that if enzyme is defective, then particular substrate will be accumulated in lysosome. Then it will keep accumulating. One time will come that the normal cellular metabolism will be affected, and then that's how organ dysfunction will culminate. So we know how this lysosome is forming. Basically, what happens, we know that these lysosome, they are actually being formed from your Golgi network. It will form. It will after formation of a vesicle, it will bind with the late endosome, and then what will happen? This lysosome will contain lots of hydrolases, and it will have membrane constitutive proteins which will be involved in transport of multiple molecules, and there will be formation of new membranes. So what happens generally with time as the lysosome matures, it it has a progressive vesicular acidification so that hydrolysis can be activated, and there will be pH dependent dissociation of receptors and ligands. And ultimately there will be activation of lysosome hydrolysis, and these enzyme will digest whatever substrate is present within the lysosome. So so what we can see that there will be a remodeling of complex oligosaccharides. These are all molecules. First, they undergo remodeling. They can have phosphorylation, sulfation, additional proteolytic processing, and there can be formation of macromolecular assemblies. And once this step is done, then these all will be digested enzymatically after activation of your acid hydrolysis. So this is how it is happening. So now you can see there are so many steps involved in the handling of this molecule. This is the reason that if there's defect in any of the enzyme, like enzyme of sulfation, enzyme of phosphorylation, enzyme of some hydrolase, or some enzymes or proteins involved in assembly formation, any of these defects can lead to disease. And that's how we have more than 50 kinds of lysosomal storage diseases. So what will the end result of defect? So suppose if defect is there, what will happen? So there will be accumulation of specific macromolecules within tissues and cells. Generally, what happens in most of these diseases, there is a point mutation in the enzyme, or there is a genetic rearrangement that will lead to some defect in single lysosomal enzyme. But less commonly, there can be defect in multiple lysosomal hydrolysis enzyme deficiency can be there because by alteration of the enzyme proteins, which are actually involved in targeting, or let's say active site modification or macromolecular association of traffic. So generally, we have isolated single enzyme defect. Less commonly, we can have multiple enzyme defect because of defect in some uh, carrier molecule, transport molecule, something which is associated with activity of multiple enzymes. So what happens once there is accumulation of substrate? It will lead to lysosomal distortion, lysosomal dysfunction will be there. Ultimately, it will lead to your cell dysfunction. So sometimes what can happen, there can be a pharmacological effect. So what happens, the substrates which are actually being accumulated in your cell, it can have their own pharmacokinetic property that can lead to particular effects, and they can actually contribute into disease pathophysiology. Apart from that, when these lysosomes, they accumulate these substances in a larger amount, then these molecules actually can activate your innate immune response. That's how it leads to your cellular injury. So one hypothesis is given in these diseases, that is known as threshold hypothesis. So what we know that we have an enzyme, it has 100% activity. So what can happen, that even this enzyme loses its activity to some extent. Maybe the body can handle that stress. For example, suppose an enzyme, if it is working 80% of its normal or 70% of normal, maybe this is not sufficient for development of disease. After a particular level, before that particular level below which if the value comes, then probably that substrate will start accumulating in significant amount. So this is known as threshold hypothesis. So what happens, we can have either endogenous substrate which are being formed in the body, or we can have exogenous substrate which are being taken by the body from outside, like supposing the food. And what happens then, this level of enzyme activity because of defect in the gene can reach below a particular level below which disease actually develops. And what happens, that if that value of the enzyme, if the enzyme activity of the enzyme changes considerably near that threshold value, it can actually lead to your disease propagation, disease amplification, or disease solution. So this is how uh, this disease happens. So there is a set level of residual enzyme which, if it is present, can be adequate for substrate handling in some tissues, and it cannot be in some other tissues. For example, now you see some enzymes can be present in all the cells of the body. Some enzymes can present more in liver, more in brain, because probably in those tissues there is need of more handling of those substances. So that's how, maybe because of different enzyme activity requirement, there is defect in different tissues. For example, the same enzyme level may be sufficient for maintaining the activity in normal cells, but may not be normal for liver, spleen, CNS, or other tissues. So that's how we have differential clinical manifestation of these enzyme deficiencies. So apart from that, what we can see, because of this different enzyme activity, what we can see that in same disease, there can be one particular phenotype when the disease is not severe, probably because they have some residual enzyme activity. And in some particular manifestations, there can be severe disease because enzyme activity is totally lacking. Okay. So now, after discussing this pathogenesis, let's see these diseases in particular one by one. We will start with Tay Sachs disease. So this Tay Sachs disease is actually very common in your Ashkenazi Jews. Carrier rate is very high, 1 in 30, and it is because of deficiency in the enzyme hexosaminidase A enzyme. And there are three forms of Tay Sachs disease. One is infantile form, juvenile form, adult form. So we can see now here only that because of differential enzyme activity, the presentation can be different. If very severe deficiency, it will present early in the life, infantile form. If some moderate activity is there, it will present juvenile form. If suppose a mild defect is there, mostly it will present late in the life. So one concept that you understand now here is that same disease can have different manifestation along the spectrum. And other thing is, now you understand that these diseases can also present late in life. So disease presenting late in life is not against the feature of lysosomal storage diseases. And as such, as if now there is no treatment for Tay Sachs disease, there is no enzyme therapy available for disease, and there is no substrate reduction therapy as well. Coming to its forms, infantile form generally present with macrocephaly, loss of motor skills, they will be increased startle reaction, and generally they present with macular cherry red spot. In juvenile form, it is less severe than infantile. Generally, they present with progressive ataxia and dementia, and generally they will be dead by the age of 10 to 15 years. In adult forms, symptoms will be less severe, but they will include clumsiness in their childhood earlier. Then they can have progressive motor weakness in their adolescence. With time, they can develop spinocerebellar and lower motor neuron signs. Then they can develop dysarthria and adulthood. and they also have progressive decline in their intelligence. And many of these patients will also have coexisting psychiatric disorders. So these are the manifestation of the disease. This picture is showing how one cherry red spot it appears. So we can see this is fundus picture from right eye. We can see these arteries. We can see small arterioles. We can see the red fundus, and that what we can see is macula. We can see this reddish macula. We can see this is known as cherry red spot. It is not pathognomonic of Tay Sachs disease. It is commonly seen in multiple diseases and also with some drug therapies. Coming to Sandhoff disease is same as Tay Sachs disease. Thus, just that Sandhoff disease has deficiency of both hexosaminidase A and B because of defect in beta chain, and it is phenotypically similar to Tay Sachs disease, except that it has few additional findings. It have additionally hepatosplenomegaly, which is not seen in Tay Sachs disease, and in some patients it can also present with bony dysplasias. Coming to Fabry disease is axin disorder, mutation in your GAL-A gene that is leading to defect in your alpha galactosidase A enzyme, and that's how alpha galactosides they are accumulated in the cells. And characteristic features which are present in Fabry disease include your angiokeratomas. They are like telangiectatic-like skin lesions. They can have hypohidrosis because of neural dysfunction, and they can have corneal and lenticular opacities, and they can have acroparesthesia, and with time they can develop progressive small vessel disease of the kidney, heart, and brain. So point is they can mimic some skin disorder, they can mimic some eye disorder, they can mimic some neuropathy like features, and they also have features of normal small vessels. So sometimes they can be confused with your small vessel vasculitis. So what are these angiokeratomas? So these angiokeratomas are actually punctate, dark red to blue black, flat or slightly raised lesions. And generally, when they present, they are usually symmetric. They do not blanch with pressure, and they're actually small and can be easily overlooked in many patients. And generally, they are most dense between umbilicus and the knee area, and that is how this is known as bathing suit area. So they are most prominent in the bathing suit area. But apart from that, actually, they can occur anywhere in the body, including the mucosal surface like oral cavity or the anal canal. And they can be seen in other disease, as we have seen already that they are commonly seen Fabry disease also. So this picture is showing how they appear. So you can see they're like telangiectatic lesions. You can see this is on the thigh of a patient. This is buttock area. This is thigh lateral aspect. And what you can see, this is the photo taken from abdomen of a patient. We can see there are multiple cherry red-like lesions which are actually raised, elevated. They are non-blanchable and small and disseminated, multiple. So this is a feature of your Fabry disease. Coming to your acroparesthesia, so acroparesthesia generally present in these patients with episodic manifestation of burning pain of the hands, feet, and proximal extremities, and it is quite debilitating. It can last from minutes to days, and generally these attacks are precipitated by your changes in temperature, exercise, fatigue, fever, and sometimes these patients also have episodes of acute severe abdominal pain, and that can resemble like appendicitis or E. coli. Eye findings. So on slit lamp examination, these patients can show some corneal lesions or lenticular lesions. In kidney involvement, many of these patients can have unexplained proteinuria. They can also present with isothenuria, and some patients can develop slow, gradually progressive renal dysfunction, which generally present from second to fourth decade. And 5% of male patients with idiopathic renal failure, retrospectively when checked, they are found to have this mutation in GAL-A gene. Cardiac involvement, hypertension is common. Left ventricular hypertrophy can be there because of your hypertension. They can have general chest pain, and congestive heart failure can develop in third to fourth decade. 1 to 3% of patients with idiopathic hypertrophic cardiomyopathy, when retrospectively checked, they found to have this defect in the gene for Fabry disease. And 3 to 5% of male patients with the idiopathic stroke in the young age also can have this mutation. Other features of the disease include they can have leg lymphedema without hyperproteinemia, and they can also have episodic diarrhea. So generally, these patients, the cause of death include your either renal failure, cardiovascular disease, or cerebrovascular disease. So management depends, because we don't have a specific therapy. Management will depend on symptom basis. So generally, these acroparesthesias, they are treated with the help of gabapentin or carbamazepine. And when there is a renal failure, then probably they can be helped with chronic hemodialysis or kidney transplantation. And there is enzyme therapy which is approved for this disease. And early introduction of enzyme therapy actually can prevent or slow the progression of life-threatening complications, but there is no definitive cure for the disease. Coming to Gaucher disease basically is the defect in the beta glucocerebrosidase GBA1G, and it leads to accumulation of your glycosylceramide in various tissues. Depending on that, manifestation will occur. So this is most common glycolipid storage disease, and there are three types. Type 1 is adult disease, which is the most common form, and it is generally non-neuronopathic. It means there is no neuron of the CNS system. In case of type 2 infantile, which is generally present in your age less than 2 years, so this is neuronopathic disease with the involvement of CNS, and generally these patients will not survive more than 2 years of age. And then third form is there, that is type 3 juvenile form, which generally present in the second decade of the life. So coming to genetic aspect of Gaucher disease, there are more than 350 mutant alleles known for the disease, and most common mutation is your 1226 position with change from A to G, that is leading to mutation, and that leads to reduction in the activity of the enzyme. And this is also the most common mutation, and this is also the most common mutation that is associated with adult form. So overall, adult form is common. Overall, this is the most common mutation. Mutation in this GBA1 gene is not only associated with your Gaucher disease, it has also been seen in association with your Parkinson disease. There is a 30 times risk of Parkinson disease if somebody has mutation in GBA1 gene. And 10% of Parkinson disease patient can actually have GBA1 mutation. Coming to pathogenesis, so what is happening? Because there is defect in beta glucoceramidase enzyme, there is inability to process glucosylceramide, and this will be accumulated in your macrophages. Macrophages will become lipid laden, and they are known as Gaucher cells. And due to collection of this lipids in macrophages, there is impaired autophagy by these macrophages, and there can be inflammasome activation. It can lead to release of cytokines. Also, there is defect in bone metabolism. There can be increased levels of osteochondrin and reduced osteocalcin that will lead to defect in musculoskeletal system, and it will lead to impairment of osteoblast differentiation. So coming to clinical features, there can be involvement of hematological system, pulmonary, CNS. There has been some controversial associated with cancers. So in hematological, generally they present with splenomegaly, hepatomegaly. They can have hypersplenism because of splenomegaly. They can have liver failure if there's infiltration of liver with these Gaucher cells. And because already there is a bone marrow infiltration, there can be cytopenias. When there is involvement of the lungs, then there can be pulmonary arterial hypertension. CNS involvement can lead to Parkinson's disease-like features, even in your Gaucher disease. And there has been some controversial associations, some uncontrolled studies are there which have shown that probably these patients with Gaucher disease have increased prevalence of monoclonal gammopathy of uncertain significance and multiple myeloma. As such, these are only known skeletal manifestations. So apart from this, there are skeletal manifestations that we see now. But there is no correlation between skeletal and extraskeletal manifestation. But history of splenectomy in the past and presence of anemia actually predicts increased risk of avascular necrosis in these patients. So, what musculoskeletal features are present in this patient? So mostly they have presence of avascular necrosis. Obviously, if Gaucher cells are there, they will infiltrate bone marrow. There will be infiltration of your um, uh, vessels. There will be increased intratrabecular pressure. All this will lead to ischemia and ultimately lead to avascular necrosis. Then there can be fracture because of weakening of the bone. There can be Erlenmeyer-Flask deformity. There can be Lincoln log vertebra. There can be bone within bone. There can be osteonecrosis of developing epiphysis. There can be chronic arthropathy. And because joint is damaged, it is more predisposed to develop septic arthritis. And when bone is infected, it can lead to osteomyelitis. So these figures, they are showing various deformities associated with your Gaucher's disease. So what we can see that this if you see this bone, this there is widen of this the distal end of femur, and it is appear like your flask. So you have seen those common flasks which are being used in your labs with triangle-like shape, conical-like shape, and that is known as Erlenmeyer flask. So this resembles to that flask. That's why it is known as Erlenmeyer flask deformity. Then what we can see, there is infiltration of these vertebrae, and this is leading to your formation of H-shaped or Lincoln log vertebra. So this is the Lincoln log. This is a kind of toy which is being used in Western countries. So appearance of this vertebra becomes like either H or Lincoln log. That is why known as H-shaped or Lincoln log vertebra. Remember that Erlenmeyer flask deformity, H-shaped or Lincoln log vertebra, these are not the pathognomonic features of Gaucher disease and can also be seen with multiple other conditions. Coming to investigations, so what we can do, we can look for the enzyme levels. There are two ways. Either you can check the lymphocyte levels, or you can culture the fibroblast and then you can measure the enzyme activity. Some biomarkers have been proposed to look for the overall disease burden. These include plasma TRAP level. TRAP is actually tartrate resistant acid phosphatase level. It is actually increased when there is infiltration of bone marrow with Gaucher cells. Then we can look for the ACE levels. We can also look for CCL18 or PARC levels. We can look for glucosylsphingosine levels. And we can also look for chitotriodase activity. So this chitotriodase activity is generally used when somebody is being given enzyme replacement therapy. So to check, to monitor whether our therapy is working or not, we are checking for chitotriodase activity. With therapy, generally this chitotriodase activity reduces. So this picture is showing Gaucher cells. You can see this is picture from your bone marrow. What we can see these big macrophages are there, and we can see there this your cytoplasm is totally packed with that glucosylceramide, and we can see it has a wrinkled tissue paper like appearance. So these are known as Gaucher cells, and it is a feature of this disease. So in imaging, we can go with plain radiograph and DEXA. Plain radiograph can show presence of your deformities, as we discussed. DEXA scan can show reduction in bone mineral density. And then when we do histopathology, we will be able to see these Gaucher cells with wrinkled paper cytoplasm appearance within these macrophages. Coming to treatment. So treatment is, there is two kinds of treatment. Either we can go with enzyme replacement therapy, or we can go with substrate reduction therapy. So enzymes which are FDA approved include imiglucerase, velaglucerase, and thaliglucerase. So these are the enzymes. Imiglucerase came first, then vela and thaliglucerase, they have been approved recently. Then how they're given? So we give a 2-hour infusion of 60 units per kg of enzyme every 2 weeks. The point is, early you start this enzyme therapy and continue it regularly, then probably the disease natural history will change. Otherwise, it will not work mostly. Apart from enzyme replacement therapy, we can go with substrate reduction therapy. So we can give either eliglustat, that is the first choice, or we can go with your miglustat. So this eliglustat and miglustat, they are basically the inhibitor of the first enzyme in the cycle. So when first enzyme is inhibited, so what happens? Substrate will not accumulate. So eliglustat is the first choice, but problem with this thing is that it is metabolized with the help of cytochrome 2d6. People can have high activity of cytochrome 2d6 or can have low activity. So people who are having a poor metabolizers, who have low activity of cytochrome 2d6, generally dose is given 84 milligram OD dose, and in case of your extensive and intermediate metabolizers, it is given by 84 mg PD. Miglustat is actually this drug came before eliglustat. It is given as 100 mg 3 times a day. But miglustat can lead to diarrhea and tremors, which are generally not seen with your eliglustat. That's why eliglustat is first choice. So you can give enzyme therapy as well as substrate therapy either singly, or you can combine them both. Treatment for MSK symptoms of Gaucher disease. So what you can do, pain, if there is debilitating pain because of infiltration, you can manage their pain. Then rehabilitative exercises are needed for these patients. Vitamin D and calcium can be provided to maintain the bone marrow density. If patient's bone marrow density is very low and prone to fracture or there is history of fracture, then these patients are candidates for your bisphosphonate therapy. When there is a avascular necrosis, it's good to go with surgical treatment. Coming to Niemann Pick disease, so this Niemann Pick disease is autosomal recessive disease. There is defect in your acid sphingomyelinase, and there are two kinds of form of Niemann Pick: type A and type B disease. Type A disease is severe disease, generally present early age of onset, less than 6 months of age, and they will have progressive CNS disease. They will present with spasticity, failure to thrive, and they will also have organomegaly. Type B disease generally present in the older age. They can have variable age as well as variable disease presentation, but generally they will have presence of hepatosplenomegaly. They will have cirrhosis, and they can also develop progressive pulmonary disease because of lung infiltration. Then in this Niemann Pick disease, what we can see, this picture is from spleen, and we can see there are multiple these cells are which are filled with this nucleic material. These are known as form cells, and these form cells are seen in Niemann Pick disease. Coming to management, diagnosis, generally what we can see, we can take nucleated cells and we can see the sphingomyelinase activity. Generally, it will be less than 10% of the normal in case of these patients. As far as treatment is concerned, as if now there is no therapy, enzyme therapy is being tried in clinical trials. Phase 3 clinical trials are going on. And role of hematopoietic stem cell transplantation or liver transplant in case of liver failure has not been established so far. So apart from type A and type B disease of Niemann Pick, there is other type C disease, which is because of defect in something else. So in type C disease, you have defect in either NPC1 or NPC2. So basically, these are lysosomal proteins which are involved in. These are lysosomal proteins. NPC1 and NPC2 are not the enzymes. These are the lysosomal proteins which are involved in trafficking of molecules in and out of lysosome. So generally, these patients also can present with CNS disease, which is progressive, but this disease develops little late and it progresses over decades rather than rapidly like in type A disease. Treatment, we can, in type C disease, we can use substrate inhibition agent like miglustat, or we can also deplete substrate with the help of cyclodextrin, but this is in only clinical trials, not in clinical use. Coming to mucopolysaccharidosis, so mucopolysaccharidosis come into picture when you see a guy with short stature with some weird skeletal deformities, some kyphosis, some scoliosis, or let's say some weird facial uh, appearance, along with your organomegaly. These are probably you're dealing with mucopolysaccharidosis. Mucopolysaccharidosis, they will present with your proportionate short stature, means they will have small trunk as well as your small body. So mucopolysaccharidosis syndromes, if we see, there are different types of mucopolysaccharidosis syndromes. Remember, there is no type 5 disease. We have type 1 disease, type 2, 3, 4, 6, and 7. So let's see. Type 1 disease includes Hurler syndrome, Hurler-Ski syndrome, and Ski syndrome. So basically, these are the manifestation of these are the diseases on same spectrum basically. So severe disease is known as Hurler syndrome, very mild disease known as Ski syndrome, and people who have intermediate features, they are known as Hurler-Ski syndrome. Type 2 disease is Hunter syndrome. Type 3 is your Sanfilippo. Type 4 is Morquio. Type 6 is Moratex-Lamy disease. And type 7 is Sly syndrome. Now we'll see some specific features of each of them. So MPS type 1, that is Hurler syndrome. It is autosomal recessive disease, generally because of defect of alpha L iodinase. And there are three categories of this disease, as we already discussed. Hurler disease, MPS 1H, MPS 1S, MPS 1HY/S. So MPS 1H, Hurler disease is severe disease, severe deficiency with features of your CNS involvement with progressive neurodegeneration. Ski disease generally is late onset, comes in little adults, and then it has manifestation without any kind of involvement of CNS. Intermediate form will be there, Hurler-Ski syndrome, severe somatic disease, but mostly there will be no any CNS involvement. So these are three kind of clinical presentation of type 1 MPS. So often present in infancy or early childhood. They generally present with chronic rhinitis, or there can be clouding of the corneas, organomegaly. Every organ system can be affected, not only these. And in more severe forms, there will be cardiac or respiratory diseases, and severe skeletal disease can also develop. As far as treatment is concerned, there are two options available: hematopoietic stem cell transplant therapy and enzyme replacement therapy. So generally, hematopoietic stem cell transplant therapy is reserved for your patient who presents early with severe disease. So this is standard treatment regime for less than 2 years of age, who appear to have high risk of serious involvement. And if you do HSCT that early in these patients, there will be stabilization of CNS disease and hepatosplenomegaly will be reversed. But this corneal disease and skeletal disease can still be progressive. As far as enzyme replacement therapy is concerned, there is benefit in your organomegaly, cardiac, and respiratory disease, but there is no penetration of this enzyme in CNS, so mostly CNS features will not be reversed. So generally, what is done, because HSCT is associated with treatment-related mortality, it is not generally tried with your mild diseases. And when you are going for your HSCT and you need to buy some time, in these patients, enzyme replacement therapy can be started. That substrate burden can be reduced, and subsequently they can undergo HSCT. That's how generally they plan treatment. So this is what I was telling you. This enzyme replacement therapy can be started prior to transplantation, and it is attempt to reduce the disease burden. And HSCT is effective in CNS disease, higher treatment rate of complication. That is why it is only taken in case of your severe disease. Hunter syndrome, MPS type 2, X-linked disorder, because hunter has an X to hunt. That's how it is X-linked. Then we have deficiency in iduronate sulfate enzyme. And manifestations are similar to type 1 disease, except some changes are there, like there is no corneal clouding or other eye disease, because hunter needs to see their hunt. Their cornea should be clean. That's how there is no corneal clouding. And there can be CNS and non-CNS variants depending whether your brain is involved or not involved. And in this patient, HSCT is tried, but it has not been successful so far. And enzyme replacement therapy is approved for these patients. Coming to MPS type 4, Morquio syndrome. So this actually present with your predominant musculoskeletal feature. So generally these patients, they present with spondyloepiphyseal dysplasia, and they can also have associated heart and respiratory complication. Generally, they present in childhood age, but age of presentation is highly variable. There can be case as early as 1 year of age, and there can be case in the late 40s. Then it is because of defect in your galnase deficiency. Type A is because of defect in your N-cell galactosamine 6 sulfatase galnase deficiency. Type B is generally because of beta galactosidase deficiency. And in case of your type 4A, because defect in galnase deficiency, enzyme replacement therapy is available, but there is no therapy for type B. So it is also although more important to find out whether we are dealing with type A or type B, because if type A disease is there, probably enzyme therapy will work in these patients. Coming to type 6 MPS, Moretti's Lamy disease, it is actually very rare disease, autosomal recessive, similar to your MPS type 1, except involvement of the brain. Organomegaly can be there. There can be bone diseases, heart diseases, respiratory compromise, and short stature is a vital sign. Then coming to MPS type 7, that is Sly syndrome. It is because of defect in Gusby gene, that is gene for beta glucuronidase enzyme. If it is there in the antenatal time, there can be presentation with fetal hydrops, stillbirth, or perinatal demise can be there. When they are born, they will have short stature. They can have post facial features, hepatosplenomegaly, and as of now, there is no treatment for this disease. So now I'll show you some pictures. These pictures are taken from various websites of rare diseases. So this picture is showing photograph of 3 patients with the MPS type 6. We can see their age 16, 30, and 12 years old, left to right. And we can see that they have telltale features of mucopolysaccharidoses. First thing we can see that they have proportionate short stature. We can see they have short trunk as well as short upper and lower limbs, and we can also see their coarse facial features and some joint abnormalities. We can see, as we can see here, we can see here, and they one of the guys is having tracheostomy here because of short neck and lack of space. Then this picture is showing presence of your enlarged tongue is there, abnormal dentition, and gingival hypoplasia is there in this patient. Then we can see this X-ray showing lateral lumbosacral spine. Only we can see what we can see that there are abnormal this you can see this is your L2 vertebra. L2 vertebra is actually pointed, and there is because of this thing there is a kyphotic deformity, and this upper lumbar kyphosis is there. Then we can see this X-ray. We can see there is no development of acetabulum socket both sides. Then there is fraying and splaying of this both sides of your femoral head epiphysis in this picture. Then we can see in this picture that if you see now, see this and this, these metacarpals are normal, but this metacarpal lower end is actually your pointy peaking, and if you see this radius in ulna, you can see that their ends are actually your little widened compared to normal. Then coming to this is showing presence of claw hand deformity in the patient of mucopolysaccharidosis. We can see presence of corneal clouding. Corneal clouding is, remember, feature of type 1 other diseases, but generally not seen in type 2 disease. Then this is what I was telling about in the beginning, that your MPS type 2, that is a Hunter disease, is actually having a distinctive pebbling of skin. You can see these small pebbles. Now see there are small multiple elevated, these skin lesions are there present this side and this side. Here also you can see, here also you can see, here also you can see. So this clinical feature is actually uh, characteristic of a type 2. So X-linked disease inheritance, no corneal clouding, presence of these pebbly skin-like lesions. If these things are present, then probably you can differentiate type 2 from other mucopolysaccharidosis without a genetic study. Coming to Pompe disease, this Pompe disease actually is a kind of glycogen storage disease, but because the defect is in lysosome enzyme, we are discussing it here. So there is defect in your acid maltase enzyme, that is acid alpha glucosidase, GA deficiency disease. This is the only lysosomal storage disease that is leading to primary glycogen storage disease as well. And there are two forms. So one is infantile form, one is late onset adult form. Infantile form presents early in the age, presents with hypotonia, cardiomyopathy, or hepatosplenomegaly. Late onset adult form generally presents as slowly progressive myopathy. It generally resembles your limb girdle muscular dystrophy. It can be confused with your dystrophies. They can also develop respiratory insufficiency. They may require mechanical ventilation. They can have dysphagia. They can also have loss of bowel and bladder control. Now remember that cardiomyopathy is generally not a feature of your late onset disease. Cardiomyopathy is a feature of your infantile form. So treatment, enzyme replacement therapy is there, but it is true that you have to intervene early. Early intervention may limit or prevent deterioration, and very advanced disease will have significant irreversible components, so therapy might not. Coming to lysosomal acid lipase disease, so this disease is basically there are two kinds of defects. Diseases are there. One is Wallman syndrome. Now it is known as infantile onset lysosomal acid lipase deficiency, or there can be cholesterol ester storage disease. Now it is known as childhood or adult onset lysosomal acid lipase deficiency. So deficiency of lysosomal acid lipase is the cause of both of these diseases. And there can be autosomal recessive mutation in your LIPA gene. LIPA gene is responsible for your lysosomal acid lipase. Function of this enzyme is hydrolysis of cholesterol esters and triglyceride delivered to lysosome via your LDL receptor pathway. So what will happen? This LDL receptor is there. It will catch your LDL molecules, will go to lysosome. There, this enzyme has to degrade it. It cannot degrade it. That is why there is accumulation of your cholesterol esters and triglyceride in the lysosome. So there will be accumulation of these cholesterol and triglyceride in various tissues. Clinically, they can have liver disease, intestinal malabsorption, heart dysfunction, and other manifestations. Generally, you divide them in infantile onset form or childhood juvenile onset form. Infantile onset form generally presents with failure to thrive, vomiting, hepatosplenomegaly, and generally patient is dead by 1 year of age. In case of your childhood juvenile onset disease, they can have variable age of presentation. They can have non-specific signs, or they can have your liver involvement in terms of elevated liver enzymes. They can present with non-alcoholic fatty liver disease. They can have cirrhosis, hepatosplenomegaly, early liver cirrhosis, early adulthood atherosclerosis, and early death. These are features of this disease without treatment. So treatment, what is recommended statin we can give, because as we know, statin will reduce your hypercholesterolemia, but it will not alter the basic progressive tissue pathology. Like in liver, there will be still accumulation of your cholesterol and triglyceride. Enzyme replacement therapy can be given for these patients. Enzyme therapy is actually approved. Apart from that, nothing much can be done. So this was discussion about lysosomal storage diseases. I would like you to focus on the tables which are mentioned in your Harrison. I would like you to focus on your distinctive and specific features which are present for each disease. Many papers they ask MCQ about this thing, and remember that these patients can present with both organomegaly, splenomegaly, hepatomegaly, as well as they can present with your bony dysplasias. Other thing I would like you to remember is that they can present at any age, and same disease can have a variable manifestation. Same disease can have a very mild presentation in the late age, and same disease can have your severe manifestation in the early age. And if possible, if we are not able to make a diagnosis clinically, there is you should be prone should be you should go for your gene sequencing and genetic analysis in this patient if these diseases are suspected. Thank you.